Catherine, before I leave, I want your opinion after this training you participated in. So many of our peers and others talk about PFA as a wonderful new technology, which it certainly is. But when compared to RF, what are some of the key differences between the two, from your perspective, that you share with your patients?
The differences are considerable. I like to tell patients that RF ablations are from heat and thermal properties, where PF uses electrical pulses. And in PVI, thermal damage can cause pulmonary vein stenosis and more readily damage adjacent non-cardiac structures, like the esophagus. PFA doesn't need heat to get a nice ablation lesion. So generally speaking, the risks can be less. Dr. Asirvatham wrapped up the training reviewing this exact topic.
Discuss what it means for a practicing electrophysiologist to understand the differences between radiofrequency ablation, many of us have used for years, decades, and pulsed field ablation. Our thought process, types of risks, things that we are actually better off using pulse field ablation for. Now, radiofrequency ablation is a misnomer. Radiofrequency does not ablate. The radio waves themselves, even if they traveled through a person at very high voltage, will not give any discernible lesion. The actual ablation is from heat, and it is like laser, ultrasound, many other experimental modalities, a type of thermal ablation. Resistive heating occurs at the interface between the electrode and the tissue, and from there the heat has to spread, and this spread is very difficult to predict even in idealized circumstances. Even after thousands of ablations, myself and many others in our field still have no surety for a given setting, given contact, what kind of ablation and what risk we are putting collateral structures to. This is one of the limitations that spurs an interest in non-thermal ablation, of which we're discussing pulsed field ablation. There's a second issue that's maybe a little bit more nuanced on why we need to consider non-thermal ablation. And that has to do with the arrhythmogenicity of the pulmonary veins to create atrial fibrillation. This was the game changer, the finding that pulmonary veins are where the fire, the AFib, actually starts in most patients. It follows that if that's the culprit, that's where we want to ablate. And indeed, the first year, 2 years of AF ablation targeted the pulmonary veins, but we had a serious limitations, and the limitations had to do with thermal injury in the vein. It got rid of much of the substrate, maybe even some non-myocardial substrates like the raw nerve endings and ganglia, but it created endothelial damage, and eventually we were limited by pulmonary vein stenosis. So pulmonary vein stenosis clearly happens only when we ablate inside the pulmonary vein. That forced our field to shift away, first to the ostium, periosteal, and then wide area circumferential ablation. Now, we got rid of the problem of pulmonary vein stenosis as long as we were strict in not ablating in the vein. But what this means is we were essentially caging the pulmonary vein. And this cage around the pulmonary vein needed just one gap. And even if you had 100 lesions, one gap would create a back to square one issue where the pulmonary vein was now 100% arrhythmogenic again. Now, you've heard elsewhere in the series about pulse field ablation. The critical piece about pulse field ablation that makes it different from thermal ablation like radiofrequency ablation is we have a direct breakdown of membranes whenever they're subjected to a direct current field. This has been known for over a century and has many applications in industry and even in medicine, oncology, elsewhere. But took a while for it to enter cardiology, mainly because in the oncology field, it was unclear whether you had an ablation lesion in the tumor on the day that you applied the pulse field. The membranes broke down, but you didn't know if you were going to destroy the cells. The mechanism by which this happens, however, uniquely lends itself to cardiac electrophysiology, since we do have two fundamental advantages of using pulse fields in our specialty compared to anywhere else in medicine. The first is the putative mechanism, not yet completely proven, but almost certainly the mechanism by which DC fields affect cardiac tissue is by enhanced pore formation. Now, this pore formation may be at sites where we already had a pore, perhaps an ion channel, an aquaporin, a water channel, or maybe in sites that there normally was cell integrity, but the DC field eventually broke down the membrane and poisons the cell with its own ions at the wrong timing of the action potential cycle and can lead to either stunning of the cell immediately or eventually complete cell death. This spurred a tremendous amount of excitement for use in cardiac electrophysiology about 10 to 12 years ago. And there are several reasons for this excitement. First, since this was a membrane effect and membranes are different in different tissues, there was a potential for tissue selectivity. A holy grail in our field for ablation is for us to know before we do our permanent lesion if we're in the right location. Test lesions. This was an advantage for cryoablation, but not anywhere near a level of perfection that we use it clinically in critical sites throughout the heart. There are other that's still investigational, but looking at pulse fields beyond electrophysiology and cardiology, for instance, to modulate cardiac function. If we compare radiofrequency ablation, first we have to remember RF and cryo are going to be thermal. They are thermal ablations. There's no other mechanism by which we get an ablation using radiofrequency energy. On the other hand, electroporation, pulsed field ablation, largely synonymous terms, can permanently ablate tissue irreversibly without any significant change in temperature. To emphasize, there's nothing non-thermal about electroporation or pulsed field ablation. With enough energy, heat will be generated, but you don't need the heat generation in order to get an ablation lesion. Whereas with radiofrequency energy, the only way you ablate is if heat is generated. The rest follows from not having heat. Structural integrity, there's no charring, there is no loss or cooking of the proteins as a result of heating that we get with pulsed field ablation. This is an early work, now over 15 years ago. Elad Maurer and one of my colleagues showed that in the rabbit carotid artery, you could actually ablate from inside the carotid artery and get a permanent lesion in active muscle cells without losing the integrity of the artery. No endothelial proliferation, no scrunching of the tissues, no coagulum, no dedenturation. This is impossible to achieve as a result with radiofrequency energy. So natural early use, and this was from some of our early work at Mayo, was to see could we get the same effect in the pulmonary veins. We know we cannot do RF ablation, but since we have this proof of concept that vascular ablation with pulse fields is possible, can we do the same with some kind of electrode design? The experimental work used a balloon-type design placed within the pulmonary veins and actually deliver energy in that location. And here is some translational results from an animal model showing that it's very similar to what was observed in the carotid artery. Before ablation, you have this viable muscle, pulmonary vein myocardium, that's gone after the ablation, pulsed field ablation, but the vein integrity is the same. There's no stenosis, there's no narrowing, there's no intimal hyperplasia. The second, and I think something very important for electrophysiologists, is uniquely in our field, we have a marker for efficacy. In the case of tumor ablation, you had to wait 3 months to know if it was effective or not. In cardiac ablation, we know in seconds, and that is because of the electrogram. The electrogram is exquisitely sensitive to ion fluxes. So if you porate the membrane and the fluxes change, the electrogram changes. Now this has become a strength and weakness of pulse field ablation. The strength is, if we don't see this, we know we have not delivered energy appropriately to that site. Another strength is we know if we are getting a lesion at the site of interest. The weakness is that this does not signify permanence of lesion. And this has to do with the field effects of pulse field ablation. The field intensity is not binary. It's an algorithmic decrease from a high intensity site. And as a result, some locations you may have enough of a field flux where we get electrogram loss, but there will not be permanent cell death. Now, if you ask an electrophysiologist who's been in practice maybe 10, 15 years or more, what was their most stressful moments while doing AF ablation? And it will almost certainly be when they were near a sensitive structure, near the esophagus, near an artery, near a nerve. Collateral damage, when it's a result of thermal transfer, is just not predictable. And it's this lack of predictability that makes it very anxiety-provoking when you're ablating close to these structures. How does this change with PFA? Well, one of the most reassuring set of data came from multiple groups where actual pulsed fields were delivered within the esophagus. Now just imagine trying to do that with radiofrequency ablation. That's asking for a stricture or worse, a fistula. But although the tissue is subjected to the electrical field, and there are changes in the membrane that happen, the key is the lack of affecting this architecture. The tissue architecture means no ulcer. And if there is no ulcer, There's no enzymatic or acid degradation of tissue planes, and as a result, the likelihood of permanent damage to the esophagus or creation of a fistula sharply decrease to the extent where to date there has not been a reported case from PFA of creating an atrial esophageal fistula. A truly remarkable development in our field, may be one of the most important I've seen through the course of my career. To get back to this concept of field flux and algorithmic decrease. Pictorially, if we look at this, there's a gradient of effects. If this is where we're delivering the maximum field intensity, electrode location, there may be and often is some thermal effect. In some studies, as little as 0.6 degrees centigrade. In others, maybe up to 4 or 5 degrees centigrade. But after that, there is an area where there is zero change in temperature, but you get permanent lesions. Then there is a penumbra area, at present poorly defined how big this actually is, where there are reversible changes. Electrogram can change for our world in electrophysiology, but you come back and check, the electrogram is back to normal. And the dose titration studies that have been done to develop the catheters and devices we use have largely focused on the zone of irreversible electroporation. And it will be the next couple of years where we understand better what this zone is like and what parameters we can change to make this therapeutic index narrower, so there's less of a reversible zone and more of a predictable irreversible zone for a given electrode position. What about the nerves? There's a lot of misconceptions that I'd like to spend a few minutes to go over. You'll hear about pulse field that nerves are spared. And yet you will see some devices specifically for autonomic manipulation using pulsed field ablation. The key is there is no tissue that's immune to pulse field ablation. But there is differences in how sensitive the tissues are. For instance, myelinated axons are difficult to get an electroporation field into. This is nice in our field because that means we worry less about the phrenic nerve, for instance. But raw nerve endings, pain fibers, some skeletal muscle fibers, and the autonomic ganglia that are not myelinated can be sensitive and may even be in some instances more sensitive than syncytial cardiac myocytes. This is an experimental study in an animal model showing epicardial electroporation delivered to ganglia on the back of the left atrium. This is a control ganglionated plexus. These are the key cells, specific stain looking for them clearly show their amelioration. So is nervous tissue immune? No. Myelinated axons are difficult to get pulse fields across, but other components of the nervous system, perhaps something we can leverage to our advantage in treating atrial fibrillation and other conditions like neurocardiogenic syndromes, are the ganglionated plexi, which may still be affected by pulse field ablation. Finally, an important question that comes up is what happens to pulsed fields when we have scar tissue. So modeling for this purpose began several years ago. On the one hand, models showed that if we had scar tissue and we had an electroporation field that was directed at the scar tissue, the electrical field itself became heterogeneous around the scar. There was a fear that this means we could not use pulsed field ablation when we had myocardial fibrosis. Translated, for practical electrophysiology, we would think about post-MAZE situations, congenital surgeries, and chronic atrial fibrillation where there's scarring. And then ventricular tachycardia would be almost off the table because that is almost universally scar-related. But what further modeling and now experimental proof has shown that the field heterogeneity actually increases the extent of the field density around scar tissue. And that's exactly where we have our viable myocardial cells that we are trying to get rid of in scar-based ablation. So in a sense, the scar helps pulsed fields focus and target the actual arrhythmogenic substrate. Contrast this with radiofrequency ablation, where we would have our maximum heat at the interface here and no selectivity in trying to ablate the viable myocardium within scar. This is perhaps one of the newest and most promising aspects of distinguishing pulse field from radiofrequency energy ablation. So to summarize, we do have some major breakthroughs, and many senior electrophysiologists think of this moment of pulse field coming in to ablation very similar to the onset of radiofrequency ablation in the early 90s. It's a true change in what we can do, what we worry less about during ablation, and perhaps increase the speed, the efficacy, and safety of the procedures we do. But there are limitations. The discomfort and skeletal muscle stimulation from the pulsed DC fields, although some excellent work is ongoing to try to minimize this, this is an unsolved problem. It's also clear that tissue specificity is really dependent on dose and electrode location. We'll discuss in another segment about the arteries. Do we spare them? Do we specially affect them? What about spasm of the arteries? And finding these thresholds, going from a mathematically predicted field and its effect on cardiac tissue to actual thresholds, A, the threshold for effect, and B, the threshold for permanency, is perhaps where the future of pulse field ablation lies.
Excellent. Well, doctor, I won't be taking up any more of your time. It was a very nice summary. It sounds like the training was really beneficial.
It definitely was. I'm looking forward to the next one. Thanks again, Dr. Marchlinsky. We hope you found the insights valuable and inspiring.
Stay tuned for Season 2, where we'll dive even deeper into the world of PFA, this time alongside our European colleagues, uncovering new perspectives and discoveries.